Dr. Matthew Weiner from the Pound to Cure Weight Loss Center in Tucson, Arizona. Today, I'm going to talk to you about heartburn or Gerd after sleeve gastrectomy. So first, let's define what heartburn is. Heartburn is a symptom where the acid from the stomach goes up into the esophagus and burns the esophageal lining. The symptom is called heartburn. The disease is called Gerd or gastroesophageal reflux disease. And around 25% of people will develop an increase in their heartburn after surgery. Now, there's also probably about another 25% who had heartburn going into surgery and actually see an improvement. So not all sleeve patients develop heartburn, and some patients who have heartburn going into surgery will experience some improvement after. And then the remaining 50% stay the same. Now, the treatment for heartburn is fairly limited when it comes to medications. We've got acid blockers like pantoprazole and omeprazole, and then we also have some what are called H2 blockers. Those would be famotidine or Pepcid, and all of these are available over the counter. The safety of the proton pump inhibitors has been questioned. That's really a topic for another video, but I think if you can avoid being on pantoprazole or omeprazole or any other PPI or proton pump inhibitor for the remainder of your life, it's probably better. Now, the big issue with the heartburn is really related to two things. The first is symptoms, and that's really where most people come to see me, is that they have significant heartburn. And it can be mild, and mild heartburn we treat with medication. However, it can be substantial, where patients will regurgitate food. They'll have to sleep propped up on pillows. When they eat, it kind of feels like a lump stuck in their esophagus or their stomach. Sometimes the food will even come out their nose at night. My general rule on food coming out your nose is, if food's coming out your nose, it's time for some form of revisional procedure. We've passed the point of treating with medication. So depending on the severity of your symptoms, we may treat with medications, or we may opt for more aggressive surgical treatment. The other thing to be concerned about besides symptoms is Barrett's esophagus. Now, Barrett's esophagus is when that esophageal lining changes from normal esophageal cells to something that resembles actually small intestine. And your body does this as a form of protection because it's just continually, day after day, being bathed in acid, and those esophageal cells are changing. They're being injured, and your body says, hey, I got an idea. I'm going to change to another type of cell that tends to be more acid resistant. And small intestine is more acid resistant than esophageal cells. The only problem with that approach is that change is not an innocent change. It does come with an increased risk of esophageal cancer or malignancy. And that's another indication I use with patients, where we may be moving past the medication management phase and into more a surgical phase, is if you do have Barrett's esophagus, especially if you're a younger person, because your lifetime risk of developing esophageal cancer, while still not that high, probably in the neighborhood of maybe 2 to 7% if you have Barrett's esophagus and you're younger. And so these are really the two scenarios where the symptoms are very, very severe, or we're seeing Barrett's esophagus, where we're going to opt for surgical management. Otherwise, we're going to lean more on the proton pump inhibitors or the H2 blockers. Now, in my practice, everybody who comes in with heartburn after a sleeve gastrectomy is going to get an endoscopy, where we put a scope through your mouth, look at the esophagus and the sleeve, and see if we can figure out what the problem is. Now, one of the common causes of heartburn is something called a hiatal hernia. Now, typically, your esophagus should be in your chest, and your stomach should be in your abdomen, below the diaphragm. That's what separates the chest from the abdomen, and that's what helps you breathe. Now, what can happen is over time, the sleeve can slide up into the chest. So the junction, we call that the GE, or gastroesophageal junction, between the esophagus and the stomach, is now up in the chest. It's supposed to be in the abdomen. The problem is, in the chest, every time we breathe in, we create negative pressure, and that opens up that valve and allows the acid to rush up. So by repairing a hiatal hernia, that valve can function a little bit better. So if you have a significant size hiatal hernia, now small hiatal hernias generally aren't going to respond to this treatment. It's got to be a pretty decent sized hiatal hernia. We can go in and just repair the hiatal hernia and not do anything else substantial. This is a pretty simple, straightforward surgery. You can go home the same day, maybe the next morning, and the serious complication rate is less than 1%. The problem with this procedure is the success rate is only around 50%. We don't see complete resolution of your heartburn symptoms the way we do with the second option, revision to a gastric bypass. We'll see around 50% of people have substantial improvement in their heartburn symptoms. The problem is, in that 50%, it may not be that durable, and that the symptoms may come back in another couple of years. And so while this is a great option because it's not particularly invasive, I don't sell it to patients or talk to them as this really effective, long-term, definitive treatment. I think if we're going to talk about definitive treatments of heartburn after a sleeve, it's really about converting to a gastric bypass. With conversion to a gastric bypass, we see nearly 100% resolution of these symptoms. And patients tell me it's like their heartburn was turned off like a light switch. And so you go to sleep, you've got severe heartburn the night before surgery, acid was coming up, it might have even been, you might have been regurgitating food or coming out your nose. The next morning, the heartburn symptoms are gone, and we see great durability of this as well. The big issue is now you have a gastric bypass. Gastric bypasses come with more rules and sleeves. No fatty or greasy food or you'll get dumping syndrome. No smoking at all, ever. Minimal to no NSAID use and minimal to no alcohol use. And so you have to understand that when you're signing up for revision surgery, you're also signing up for these lifestyle restrictions. A lot of people question how much weight they'll lose after the surgery. And in my opinion, this is a great surgery if we do it for heartburn. When we do it for weight loss, we see fairly modest results. In patients who've regained a lot of weight, we'll often see them lose that weight that they've regained. They may not get lower than they were after their sleeve, but they'll probably get somewhere in that neighborhood and have an easier time maintaining it going forward. In patients who are already at their lowest weight or near their lowest weight after their sleeve, we may see a few pounds of weight loss, but not a ton. I'd say 10, 20, 30 pounds in that scenario. And this is a lot of surgery for 10, 20, or 30 pounds. And so in my practice, I really encourage that our patients to select this procedure for the treatment of acid reflux. I think if that's what your problem is and that's what's bothering you, you're going to have a great result with this procedure, near complete resolution. If you're looking at it for weight loss, my hunch is you're not going to get as much weight loss as you think, and you may be disappointed, and that's probably a better scenario for using the newer GLP-1 medications. We'll have separate videos down the road talking about weight regain after a sleeve and treating them with the GLP-1 medications like Wegovy, Ozempic, and Mounjaro. I hope this video was helpful. See you next time.